We initially started this project back in the summer when Pat came forward, and it's been, I worked with Pat how many years ago? Many years ago, and so it was good to start this again. And what was really very nice was that we've had to move rooms because there were so many people that were interested in attending that we had to move to a larger room. So that's always a very good sign. So thank you all for attending. Thank you to our panel and moderator. But I'm going to pass things over to Pat, and she's going to give you a little bit of background of how we come to be here this morning. So, Pat.
That was Rhonda Cockrell. And I'm Pat. She's from U of T. I'm Pat Armstrong, and I'm from York. And I'm the principal investigator on a project now into its 8th year called Reimagining Long-Term Residential Care, an international study of promising practices. And you're welcome to pick up 2 of the booklets we've produced that are out on the table there, and we have many, many more publications. It was in the process of launching our most recent book and booklets, as we call them, that I encountered Lawrence. Lawrence came to that event and suggested we meet to talk, and when we did, we suggested, especially Jim Struthers, who had previously interviewed Lawrence 25 years ago about his job, that we should interview him again. And Lawrence said, instead of interviewing me, why don't we have a panel? So that's where this panel came from. And I'm delighted to say that Gail Donner instantly agreed to moderate this panel. As I'm sure many of you know in this room, she's a professor emeritus from the University of Toronto. She has an Order of Ontario and an honorary degree from Ryerson. But what's particularly relevant to today is she's been the head of 2 different task forces in Ontario, one on long-term residential care, and one on home and community care. So she's truly an expert in these areas and has a lot of experience to draw on. So I'm handing it over to you, Gail.
Thanks, Pat, and thanks, Pat and Rhonda, for inviting me to do this. It's especially gratifying to see a collaboration between York and U of T. We all know that doesn't happen very often. Maybe it'll be a model for other projects in the future. So we have a short time together because apparently there is a class here at 10 o'clock. So I know we need to be out. So I've already warned Lawrence and Paul that I'm going to be a tough taskmaster this morning because we have a really unique opportunity to learn. Pat mentioned that I have a lot of experience. I would put myself as a child compared to the combined experience and expertise of our 2 panelists this morning. We really have a phenomenal opportunity to listen, to learn, and to talk with 2 people whose experience and expertise is really legendary, particularly in relation to policy and residential long-term care. So the title, Looking Back, Thinking Ahead, Lessons from Early Policymakers, I think is apt, and hopefully by doing a little bit of looking back, those of us who are interested in making change will be inspired to keep up the good fight. So what I'm going to do is I'm going to introduce both Lawrence and Paul. The resumes of each of them could take the whole hour and a half we have. So I'm going to very much touch on their experience. And I'm sure when we listen to them speak, the richness of their experience will come through much better than any introduction I could offer. Then what I'm going to do is I have a couple of questions I'm going to ask them. And then I'm going to try to hold them each to about 15 minutes. And then that should allow us a fairly significant amount of time for some discussion, after which I'll give them each the last word in case they have a last word, and then we'll adjourn. So without further ado, let me introduce Lawrence Crawford, who's sitting to my immediate left. And Lawrence worked as a senior advisor in gerontology and a policymaker for the Government of Ontario from 1956 to 1985. During his long career, he served as the director of the province's Home for the Aged branch, its Office of Aging, and its senior secretariat, and facilitated numerous provincial conferences and government investigation into the consequences of population aging within Ontario. I first met Lawrence when he came to a board meeting of the Regional Geriatric Program of Toronto, and found in that brief presentation had the opportunity really to see what the benefits of such a long and distinguished career brings in terms of wisdom. Next, obviously, is Paula Krafka. He also worked in leadership roles in long-term care from 1976 until 2014, and he does so now in a volunteer capacity. As a matter of fact, we were talking about the term retired, and maybe retired moves just to professional volunteer. I personally just call myself a failed retiree. I'm not sure. I haven't met very many retirees who actually are retired. Most don't even know what it really means. In addition, he served as a senior administrator in long-term care homes and has participated in a number of government and community policy panels. He was president of the board of directors of the Ontario Association of Nonprofit Homes and Services for Seniors, which you may know now as Advantage Ontario, and has received multiple awards that recognize his contribution to the life of seniors. So with that, this session is being taped, so we have to use the microphone. So when we get to the discussion, I'll ask you to just put up your hand and hang on until you get a mic. And without further ado, Lawrence.
Thank you, Gail, and good morning, everyone. I'm neither going to look back right now nor look ahead or think ahead. I'm going to look at the very present, and I'm sorry if I depart slightly, but I put a poster outside, "Disaster, are we prepared?" And I just want us at this moment not to be too celebratory, but to think about the men and women who were murdered in southwestern Ontario by a very troubled nurse. I also want you to think, on Sunday I read the New York Times about the 8 elderly men and women who died from heat exhaustion in a nursing home that had no standby generator to maintain the air conditioning, and the staff left them. When one woman reached the hospital emergency, the temperature in her veins was 108. And those of you who are health professionals will know that that's probably not the particular temperature that can maintain life and sanity. I hope we will all remember the men and women who have suffered in these kinds of situations right currently. But I'd also like to pay tribute to the many professionals right across disciplines who do labor with dedication and true love for residents of my generation. So both. I have handouts that deal with the legislation that was extant in 1970, and the focus I made there was, in my time and my predecessors, we focused on the administrator. We were careful in how we selected administrators. We weren't looking entirely for qualifications, though they were important. We were looking for personality. The legislation actually says an administrator shall be of suitable personality. Well, how do you define that? Can you teach empathy? Can you detect it? Well, I'm told there's an MRI that can actually test for empathy. We weren't trying to do that, but I think inculcating those attitudes, the administrator could be the focal point of all else that happened in the home, along with the home physician and the director of nursing, and possibly social workers and other therapists, but also the kitchen staff, and as Pat Armstrong's book indicates, even the laundry staff and housekeeping. So my focus in the handouts you will receive is on the administrator. And in the legislation I administered, it says the administrator shall hire sufficient staff to perform his duties or her duties. It wasn't the ministry which decided how many RNs. It also says the administrator shall buy sufficient food of nutritious value. Nobody set a food budget. And while we're on that, I hope that when the public inquiry into long-term care goes forward, Judge Galeese will ask how the two ministries of Ontario, Health and Long-Term Care and Correctional Services, devised their food daily budget. Somewhat askance when you read that prisoners in Ontario jails are allowed more per day than seniors in long-term care. That's all I'm going to say now. I hope we both remember those who passed away, unfortunately, and also remember with gratitude those members of staff who labor in the field. Thank you.
Thank you for spending a portion of your morning with us today. It's my pleasure to be here, and I would especially like to commend Dr. Armstrong and her study partners on the 4 central themes they focused on over the last 8 years. It amazes me that somebody could have, and a group of people could have, that level of commitment. And their main focus areas are approaches to care, work organization, accountability, financing, and ownership. And I strongly believe that if we could get the answers to those 4 areas correct, we'd have a system that we could all be proud of in residential long-term care. My focus over the next few minutes in the discussion here and in the paper I've distributed is intentionally much narrower. I'll look at 2 main areas. Firstly, admissions to long-term care in the 1970s, 80s, and early 90s versus now, with a focus on resident choice of where they'll live and who they'll be cared for. Secondly, I'd like to look at a solution around facility and bed construction towards ensuring that we had adequate availability via a new financing option and not simply relying on the residents to pay their own way and the tax dollars to build those facilities. At the outset, I must admit to having a strong bias in favor of not-for-profit long-term care in general, or specifically, and healthcare in general. I fought this battle my whole 40-year career. And I've worked in the not-for-profit sector. I've lobbied locally and provincially for the sector. I donate and fundraise for the not-for-profit facilities, and I believe they're the best way to go in terms of facility-based or residential care. I hope that our discussion benefits from some of the specificity in the notes I've given you. And although I hesitate to hand out notes in advance because people will sit and read them from time to time, that's what I do, but it's better than reading the Globe and Mail. Resident choice of where they would live, I believe, is a primary factor in the success of moving people in to what I still refer to as home for the aged or long-term residential care facilities. It was the primary focus in the 1970s and 80s, but definitely isn't so today. We moved from that focus of resident choice to equity in admissions and everybody having equal access to all of the facilities. But that comes at a loss. Two things changed this. In the early 1990s, all remaining residential care beds were converted to extended care or health care. Residents whose care needs were too great to allow them to be admitted prior to that time were now the only ones who could be admitted. So we lost something of significance. Again, that whole resident choice piece and the whole residential piece. However, at the same time, and to government's credit, more services were funded by the province to support the well elderly in remaining in their own home in the community. These included respite care, home care, Meals on Wheels, bathing, and some housekeeping. It also required, however, a lot more support and care by family direct caregivers. As a result, when residents needed facility-based care, they came in a much frailer state, and by the time they needed it, many families were already burned out and needed immediately, not 3 months or 6 months or 9 months down the road. Levels of care funding was introduced to provide equity between facilities based on the care required by their average resident against the average resident in the province of Ontario. This was a great concept, but sadly on introduction of it, the province underfunded that system by 20% based on the actual care needs of the day. And that underfunding has never been responded to since 1993 when levels of care funding was introduced. New funds have been added, but nothing covered the basic need of the residents in 1993. So what do we do? How do we solve this? I think the first thing is to go back to a system that provides resident choice as a primary factor. Resident choice in the facility they'll live in and who they'll be cared by. Provide adequate numbers of beds for people on approved waiting lists, including those in crisis, and especially those in crisis. Today, we admit 70 to 80% of the residents being admitted to long-term care over the last 10 years are crisis admissions, meaning they have no choice in where they're going to go. Have staff from the resident's facility of choice meet with residents and their families in their home or hospital to do an appropriate needs assessment, or what we called back in the 70s and 80s, a social assessment. Introduce the residents to the home they're going to live in, not just to what long-term care is. Do this by using computer databases to match resident choice with available beds, and over time, using that data to adjust capacity. And most importantly, don't accept anything less than optimum solutions. In the paper, if you read along, I talk a little bit about how to build new resident beds, and especially how to build them without using taxpayer dollars and without burdening the residents who live in the facility. I think it's important under that model, and you can read it in the paper, but basically what it does is allows the resident, a portion of them, a very small portion. In my model, I've used 10% of the available beds in the province. Allow the residents to buy those beds back on something similar to the life lease housing model. There would be lots of detail to work out, but when we started life lease in the mid-1990s as a housing option, there were lots of objections to it back then as well. And by trying it, it can work. By allowing simply that to happen, many, many more beds can be built immediately, not waiting 10, 15, or 20 years. And right now, we have 56,000 beds either needing to be built for the 24,000 people on the waiting lists in Ontario, or needing to be refurbished, where we need 32,000. In my paper, I said 30,000, but I got updated stat on the weekend. 32,000 beds have been identified as by the province as needing to be rebuilt. These can be done with residents' or seniors' dollars. Not all seniors. We can still take care of the poorest of the elderly, the most marginalized. We can still provide care to all of the residents under this model, but the housing portion of their cost, they can pay for. A small number, but that small number can make amazing difference to the provincial budget and an amazing difference to the deficits caused by the need to build capital or build new beds in facilities. And I'll leave that with you. Lots of interesting stuff in the paper, and I hope you enjoy it.
I think we can see that our guests today have some very clear ideas, not only about what we haven't done, but also what we need to do. And if I can just take the moderator's prerogative for 1 minute, what I heard thematically in what both of our guests have said is that we've been focusing very much on, and it sounds very old-fashioned to say, but still something we have not been able to move our system towards. We've focused very much on something that fits and suits the provider, whether capital P or small p, and really particularly, I would say, in long-term residential care, as well as in home and community care, we do not yet have a needs-based system. And trying to shift that, as the old cliche goes, is probably more difficult than moving the Titanic. I think that's something I know some people in the room work hard on this every day, and I think it's something we should not give up on doing. So I'm going to start, Lawrence, if I can, with you, and just ask you, you made, I think, a very strong and compelling argument around administrators or those who manage and long-term care, long-term residential care. But maybe you could talk a little bit about where we've lost our way. That is, you talk about the kinds of policies that were in place to recruit particular kind of administrator. You use the term empathy. You talk about meals, etc. Where did we lose our way, and what do you think we need to do to get back on the path to, I won't say administrators, but I will say the management of long-term residential care, so that it reflects more the needs of clients, residents?
Well, I'd like to just put that in the context of who the people are that are being served. When we talk about long-term care, I think we make a mistake today if we think long-term care is a building in which people are located. The people in need of long-term care are living everywhere right now, in their own homes and apartments, in unlicensed and unregulated boarding homes, of which some were in the news in this city about a month ago, and I'll come back to that one, in affordable housing. Toronto Community Housing, a young social worker friend of mine from Sunnybrook, goes into these homes, and he said more than half the people he sees with his psychogeriatric outreach team ought to be in long-term care facilities. And then we have our present-day long-term care homes, but a few years ago we had chronic hospitals. Most of them are gone. A few years ago we had psychiatric hospitals. Most of them are gone. And that particular move in the 70s, when new psychosomatic drugs, or antipsychotic drugs, came on the market, allowed some politicians to say, well, patients don't need to be in a psychiatric hospital. We can give them a package of pills and send them out. And they did. And there were some disgraceful episodes in the UK, in the US, and even here in Ontario. So our homes now are actually serving a population that in earlier days was in a chronic hospital or in a psychiatric hospital, and they are becoming more and more, with the dementias, the preponderant population. Last Friday, Pat had a session with some long-term care home physicians that was very enlightening, and I remember that the one doctor said, the long-term care or nursing homes of today are becoming the general hospitals of yesterday. And I thought that was a very telling remark. So where did we lose the way? I think there were so many changes of downloading and offloading that the system now is plugged. And we need to go back to assessing the individual and their needs rather than saying this building serves this group and this building serves that group. I don't know why we lost that way. I think we can recover it. As Canadians, we are fortunate if you watch your television news about what's happening in Washington on the Affordable Care Act and the repetitive attempts to create something else that will be a disaster for millions of Americans. We are indeed fortunate, but we have a long way to go to recover and to create new services.
Thanks. Maybe before I ask you, Paul, to answer a similar question, do you have any comments related to what Lawrence has said? Because this notion of being plugged, I quite get it, and a frustration of mine as well, and I'm still trying to figure out what's the magic to unplug things.
I think in terms of what Lawrence has said, and I'll go back to what he said from the podium, the training and selection of administrators is crucial, absolutely crucial, because from there, the tone for the whole organization is set. And I think back over my time in long-term care of all of the people who became administrators by accident. I think of a lady, Mrs. Hicks, at the Elliott home in Guelph. And her husband was the administrator of that home for many years, and he suddenly died of a heart attack. And the board there said, I think her name was Eileen, but Mrs. Hicks, can you sit in your husband's chair for a week or two or a month while we find somebody? 20 years later, she was still running that facility and running it better than most administrators in the province of Ontario. Another young lady named Carol Shaw did exactly the same thing. Just happened to be there, and they said, can you sit at the administrator's desk? She went, she learned, she got the academic preparation, but it was who these people were that was so important, and I believe is so important today.
So I'm going to, I could ask 25 questions, but that's your job. My job is to moderate. I don't know why I say I'll do that, because I'd much rather be where you are. But anyway, I am going to shift gears a little bit and ask you the same question I asked Lawrence, Paul, related to the whole notion of beds and places and spaces. Where did we go wrong? And I think you've got some very interesting proposals of what we need to do to make it right. I think I'm still looking for the magic that needs to happen to turn, to put us back on the path. So maybe you could just expand a little bit. I know there's more in your paper, but folks, I don't want folks to sit and read the paper right now.
I'd love for you to read the paper because it's far more articulate than I am. Where did we go wrong? I don't think there's a single reason or problem, but I think as Lawrence has mentioned, the discharge of the people from the former mental health hospitals or the residential mental health facilities, and with no place for those folks to go, is crucial. The fact that we've turned residential long-term care into health care as opposed to home, I think, while I understand why that needed to happen, and I understood at the time the pent-up demand, it still needs to be home first, not a healthcare facility first. When you're ill at home, your health doesn't dictate your whole life. And I think we need to build on the strengths of the seniors in those homes and build up those strengths. And I think that's a big part of the solution. The other big part of the solution is ensuring there's enough money. And I've been riding the hobby horse of residents owning their own beds for a long, long time. And I know there are a lot of objections to that, but there's so much good in it, and it can provide so much cash. And the other piece it does, it allows the resident to maintain that pride of ownership that so many seniors have had their whole life. The only thing they had was the home they lived in, but they saved and they sacrificed for that. And to have that pride of ownership, I think, is still important to a segment of our society.
I just want to add there that there were two other factors in where we went wrong. The first is political. In a red sheet that I've put out urging everybody that you'll pick up afterwards, support the public inquiry headed by Justice Eileen Galeese, I refer to a book published by U of T, social scientists here and health professionals, Almost Home. And that lists all of the different political shenanigans that went on from the Peterson government, the Ray government, and the Harris government. Each set of ministers announced a wonderful strategy, agenda, focus for the future, and the next government came and wiped it out and started afresh. The result was a hodgepodge, and nothing much happened. And I think that's an area. The other one is the way in which now things are referred to as a system. About 5 weeks ago, it was discovered that an unlicensed boarding home in Toronto was housing seniors, and the fire department and public health said it was unsafe, unsanitary, and there was a meeting at which officials from the Ministry of Health and Long-Term Care and Toronto Police Services and the Attorney General's office sat down, and since they couldn't come up with a strategy to deal with the matter, they did nothing. They decided to leave the men and women in place. Now, it isn't systems failure that we should be addressing, it's personal failure on the part of all those who have responsibility.
What's the old saying? Them's fighting words. So I'm going to open the floor, and maybe Neil? It's easy. Maybe people could introduce themselves just for a second so that our panelists have some idea of the...
Sure. I'm Neil Stewart. I'm an engaged retiree. I don't know, maybe a failed retiree, Gail.
None of those.
Sort of two unrelated questions. I was really taken by Lawrence's proposition that the administrator has such an important role in sort of setting the tone in their personality. I guess the question I have, which is really just a fact-based question, do we actually have residents and family members of residents interview administrators when they're appointed, and do we involve them in their performance evaluation? Because that would seem like, if that's truly part of the secret to kind of getting it right, then that would seem like one thing we could be doing. And I guess I'll just throw out my other question now and leave it with you. I wasn't sure, Gail, I mean, your question about where we went wrong, did we ever have it really right? And I guess I'm sort of reflecting back on my graduate student days, and we all read Bruce Vladek's Unloving Care, which admittedly was focused on the US and was focused on for-profit care, but it seemed to me that there was a sense that we had a job to do back in the 70s and 80s. So I'm not sure if we ever had it, but just a question.
That's a good point.
Just on the involvement of patients and families in interviewing, I don't know, I'm going to leave that to Paul, but I do know that the Kingston General Hospital some years ago actually involved patients and some family council members when they were making their final selection of senior personnel in the hospital. Whether that's still carrying on, I don't know.
We don't directly have patients or residents, family members involved, but we have a good proxy for that in the not-for-profit homes where they have boards made up from the community. And in the 4 facilities I've worked in, those boards are very much in the home, very much there talking to the residents as part of their day-to-day life and just observing. And I think that proxy is very good. Also, the quality efforts that take place now, we get very good feedback on all elements of operation of the home through that quality report.
So thanks for making the point, Neil, that we probably never had it right. I think we never paid much attention, period. Now we're trying to pay attention at a time probably when we've devoted so much money, attention, status, particularly to acute care, that we really have left the leftovers in every way that you can define that for long-term care. And that sets up a battle that probably is not necessary, but nevertheless seems to be a constant. So that's one maybe thing I'd like to add. The other thing is that I think the issue in the management of long-term care homes and in administrators, et cetera, is quite variable. So in the work that I did a few years ago, we saw long-term cares where boards had very specific guidelines for recruitment. They had a more open process. They had a member of the resident council and sometimes a member of the family council on the recruitment team, etc. But I would say in still the majority of the ones that I became familiar with, it was all over the map. And some of the examples that you used of, so-and-so's spouse or so-and-so's sibling or whatever, this is a family-run operation, and the grandfather did it, and now the granddaughter's doing it. That still exists quite a bit, and where folks are good, it works out fine, but of course. Now, there are all kinds of regulations. As a matter of fact, I would argue that long-term care is over-regulated, and rather than trying to seek solutions through process, we've used a big hammer, and that doesn't solve anything. I'm not a fan of laissez-faire, but some regulation is good. Too much regulation takes away any opportunity for judgment, any opportunity for group problem solving, etc. But I think there are now requirements related to quality, etc. But the problem is there's not a lot of attention to education, to working with. So there's you're good and you're not so good and you're bad, but there's nothing around how can we help you do the kind of work you want to do. So I think it's a complicated area. Are there other comments, questions? Just remember to say who you are.
Hi there. My name is Hussein. I'm a PhD student here at IHPME. My question is for Paul. I'm hoping you could elaborate a little bit more on your residents owning their own beds idea, because perhaps I have a little bit more
Keep
of a
the microphone right close.
Perhaps I have a bit of a utilitarian perspective on things, and I'm worried about fairness and equity and those kinds of buzzwords. Could you elaborate a bit more on that idea and whether or not equity and fairness are preserved or compromised? And do you have any examples of other jurisdictions in which this idea has been implemented successfully and equity is still preserved long term?
Great. Thanks, Hussein. First of all, I think several of the primary objectives are exactly what you say. Equity has to be there. Equity isn't there in our society today in many, many elements. Those people living in $3 million homes in Toronto are not living equitably with those people living in not-for-profit housing. Those people living in private rooms and paying a big co-payment, and in semi-private rooms and paying a big co-payment in long-term care today aren't living equitably with those people living in standard rooms as it relates to their accommodation. But the key point where equity kicks in is, and the thing that has to be assured, is that everybody's health care, all the services everybody receives, are equal. The other important part to equity is in residential and extended care in homes for the aged. When I started, those people in residential care for 40 years supported those people who were part pay. And so all we're doing is taking that same model that worked really well, and it's almost, I always referred to it as the Robin Hood model, but it's those who have support those who don't. And by giving some money back to the facilities so they can pay down their deficits, they can provide more in care to all of the residents and direct some of that money directly to care of the residents. By the province not having to build all of the new beds that are needed, there's money left over for other things. And that's where the equity piece comes in and the social justice piece comes in my mind. In terms of models where it worked, life lease housing is the best model that I've seen in Ontario of that. Very, very successful projects, and in my own facility, we have 107 life lease beds serving 200 seniors, and those beds or those rooms, every time they turn over, contribute something back to the organization as a whole and support the long-term care facility on that site and on many other sites in Ontario.
Thanks. For other jurisdictions, I recommend Pat's work to you. In their work, they have quite a bit on long-term residential care in other jurisdictions. I think there were just one there and one there.
Hi, I'm Jim Struthers, an historian of long-term care in Ontario. I'm just always in long-term residential care, there's been a tension between social care and medical care. And for the first half century of long-term care policy in Ontario, that tension really was worked out between the division of labor between the Ministry of Community and Social Services, which had responsibility for homes for the aged and the charitable nonprofits, and the Ministry of Health, which regulated nursing homes. And then in the 90s, those two were brought together under the Ministry of Health in the last 25 years. And I'm wondering, I'd like to ask both of you who experienced that change and that system, whether you think that was a mistake, whether that was a turning point, whether we lost something of the creative tension between those two ministries in negotiating that balance between social care and medicalization.
Well, if you go back historically, you are going to see that during my time, at any rate, nursing homes were not regulated by the province of Ontario. the Minister of Health of the day flatly did not wish to be involved with nursing homes. And so Community and Social Services drafted model bylaws which municipalities could enact if they were paying for men and women in a nursing home. So it was very spotty across the province. As to how the two came together, well, that would be a very long story, and I think in some of your books and in Veriton's history of the privatization of healthcare, that's touched on.
Yeah, in 1993, when the legislation was created to bring all facilities under the Ministry of Health, I think it was a big mistake. I think that tension, positive tension between the two sectors, the private sector or private for-profit sector and the public sector facilities, was very positive. And I asked one of my colleagues who was a leader in long-term care what he thought the major issue was in long-term care today and what are we doing wrong that we should fix. And we talked about raw food, we talked about policy, we talked about legislation, but then he sent me a voicemail, and I wish I could play it for you, but he'd be quite embarrassed. And he said, basically, the worst thing in long-term care today is the implementation of compliance and inspections and policing. And his comment was, no compliance advisor has ever done anything to improve resident care in a long-term care facility. And we invest way too much in policing. I don't go quite as far as that, but I think he makes some very good points. And if more of the money that's put into policing in Ontario, which we don't have in most other provinces in Canada, were put into the care of residents and into the operations of the facility, we'd be a whole lot better off.
During my day in my office, I never used the word compliance officer. I didn't hear of it until the 1990s. I referred to my staff as program supervisors and program consultants. And in the reg that is in my handout dealing with food service, there's nothing about any detail. We had a team of 5 nutritionists in the Ministry of Community and Social Services who visited and discussed menus and food choices and ethnic preferences and worked together with the home administrator and dietary staff to bring about improvements if they were needed. It was collaborative, it was a partnership, and I fully agree that the compliance, the very word when I heard it, just put the hair up on the back of my neck.
My tongue is going to be bleeding shortly just from biting it, but I'm going to be a good moderator.
Hi, I'm Carolyn Klubine. There is so much to mine in the comments that all 3 of you have made. It's hard to know which of the things that you've said that I'd like to fuel. But I would just go back and say that in my experience, I was director of long-term care with Regent Peel and saw different administrators in different homes, and the culture moved with the administrator. We had the opportunity to circulate some people between facilities, and the culture seemed to revolve around their style. So I grant the comment that Lawrence made is really telling. What I did want to kind of ask for some response to is the notion of belongingness and community. It seems to me that one of the features that can best serve seniors in their frail years is being part of something that provides them support and care more so than the actual place that they are located. They may change settings based on temporary needs or concerns in their own personal setting, circumstances. But I'm just wondering if you might respond to the idea, are we missing this notion of belongingness and cultivating that with our seniors in how their care needs are met?
One of the things I regret not pushing more is intergenerational programs within the facilities. When the Italian-Canadian community built their home, Villa Colombo in Toronto, and when the Chinese-Canadian community built Monshang Home, and I was a founding member of that board, the two things that the groups brought in were young people. The Chinese community used the home for language lessons so that children were learning Chinese from their elders. It was different to school. In the Villa Colombo, they had a daycare center, and the nonas were going from the home into the daycare. And this is a form of community involvement. And a lot of seniors who don't have grandchildren, some of them never had children themselves, miss that contact with young people. There are a whole lot of programs that I deeply regret we didn't push more. Music, other kinds of therapy that allowed people to be involved in a more comprehensive way. Anything, Paul?
Yeah, I think that integration, intergenerational, is extremely important. I experienced that recently at St. Joseph's at Fleming in Peterborough, where Fleming College initially, when the facility was built, put a child daycare center and did training of their child daycare students right in the facility. But one of the really neat things was we had integrated programming at least twice a week with the residents and the children in the daycare, and it made an amazing difference. So that integration is extremely important. The other part to that, and Lawrence referred to it earlier, is the importance of some of the ancillary staff in the facility. And my experience at St. Joseph's Villa in Dundas really brought that to mind. We have a lot of long-term housekeepers there, and they have become family to many of the residents who have no family. And I would see them out in stores on a Friday evening using their own money to buy nylons for residents where they couldn't get that specific pair of nylons, and other things like that. One housekeeper brought in her Harley Davidson and brought it up and put a 100-year-old resident on the Harley, dressed her in her leathers, and just little touches like that. A gardening program from one of the schools came into the school, and then the residents went back and taught cooking in one of the home ec classes, and that interaction is just so important. I'd like to go back to just one other point. Somebody, the gentleman here said, did we ever have it in long-term care? I think we've had it many times, and I would refer you to the book, and I refer to it in my paper, For Such a Time as This, by Norma Rudy. And Norma is just an amazing lady. She's into her 80s now, but she did a history around Earl Ludlow and the first 104 years of homes for the aged in the province of Ontario from 1837 to 1961. And Lawrence, actually, I was quite amazed in rereading the book that he did the foreword to that book. And I think we've been doing it right for a long time, but it's an incremental approach, and we keep changing how we do it. And it's good people doing good things all along the way that really make that difference.
I'm glad you mentioned the folks who work in residential care as well, because I think your notion of community is bigger than just the community or the sense of belonging that residents look for or would benefit from. It's also community writ larger, and as you said, a lot of folks who work in long-term care have been there a long time. And I remember when we were doing our work a few years ago, people talked so movingly about, you know, I do this because I love it. I love older people. I always wanted to work with older people. I just wish someone would help me do it well. Or I just wish people respected older folks more. So
I was horrified. I wrote to a number of my former colleagues and retired staff members, and one of my social workers, now retired, wrote me back about her experience in the Kingston Frontenac area. Social service personnel are trying to force people receiving assistance to go to a community college and find work. And they are suggesting to any number of people that an easy course is for PSWs. And these people are not happy about being pushed into this. They don't want the jobs. And in other words, somebody is saying a PSW is not a very important person. Anybody can do it. Well, believe me, when my wife has been at home after serious surgery, when I've been in respite care, a PSW is a very important person. And their personality and their skills, they may not be the highest, but they're very personal and they're very important. And yes, we need to support more of all levels of staffing. And just so I don't forget, I was reading in the library the other day, I go and catch up on things. In the Harvard Business Review, a statement stuck in my mind. Two economists used this sentence: an underfunded government program is just another way to waste money. And think about that. An underfunded government program is just another way to waste money. You would be better not to spend the money than to spend too little and have a service that is of no value whatsoever.
thanks. There, and then there's also someone at the back.
Good morning. My name is McKendall. I'm a surgical nurse. In my field, it's a lot that there's a stress placed on getting people out of the hospital and moving them into the LTC. Daily, it costs about $1,500 to $2,500 to the taxpayer to keep someone at the hospital. So when I was interested in what Paul said about life lease, I just wanted to know how much less is it on the taxpayer to as opposed to what it is now. So what is the price of, what's the government's contribution right now, and what's the difference with life lease?
So using the life lease model would simply be a difference in capital. So it would be no difference in care, in food, or anything. In fact, those, in my proposal, would be identical. But to your point, in terms of getting people out of hospital, we had some vacant space where about 150 residents had lived in Dundas in the facility after we rebuilt, and we hadn't repurposed it yet. We still haven't repurposed it 10 years later. But one of the things we did, the two hospitals in town, Hamilton Health Sciences and St. Joseph's Healthcare, both had a big alternate level of care, or ALC, problem at the time, and still do to some extent today. So we partnered with those hospitals and opened, I think, 72 beds to provide what we called transitional care. But the really neat thing about it was it saved the hospital lots of money. We could do it very inexpensively in space we already had available, and we had no government regulations to deal with. The long-term care division absolutely hated us because they came in and said, wait a minute, you've got people in this building who aren't residents, who aren't covered under the Long-Term Care Act, but we had people receiving care, gently progressing to the point where they could either go to a long-term care facility if that's what they needed, or they could go back home. The LHIN came along and they didn't like that because we had created a partnership between 3 partners without involving the LHIN, because the LHIN weren't in place to deal with it yet. They had just started. So they came and reworked the program, and they now call it Assess and Restore. And they provide us with the same amount of money to do 42 residents as we were doing for 72 before.
I do want to draw your attention to a big display outside. I volunteer with a program in the Regional Geriatric Program at Sunnybrook, and my colleague Ada brought the poster down. We are running a senior-friendly hospital program, which involves 3 elements: engage, energize, and eat. In other words, we're focusing on respect and dealing with the individual. We're bringing about mobility so that there's not hospital-induced frailty and loss of function, and we're focusing on an adequate diet. It's a wonderful program, but the problem I now see is we discharge a patient from that program, and we have no idea what's going to happen to them once they leave the hospital and are back in the community. There's such an inadequacy of communication and services. I have a couple of quotes in the handout that's going to be at the back when you leave that are very crude, but they're written from the heart by 2 sons of a mother who was left by the system unprotected and unserved.
Judy, word integration, I think. I think there was a question down there, or comment.
I'm Aaron Jacobs. I work at City High Institute in Health Policy. I have 2 kind of financing questions, or financing opinion questions, I guess. It seems to me that some of the conversation has talked about like reforms that could be made, things that could be improved. I'm wondering, in both of your opinions, how much of it is we can improve things with reforms that don't require more money, and how much of it is really nothing will change unless we get a big additional source of public money into the system. And, you know, sort of somewhat assuming that you're going to suggest we should have more public money, what will happen in the future if that public money does not materialize?
I think, totally in agreement with you. I don't think we need more public money. In fact, I think we need less public money. And the model I've proposed, and I would encourage you, because that model is very simplistic, but it's very basic. But if you have thoughts on reading it, reply to me, because I'd like to refine it. I'd like to fine-tune it. And I'd like to make sure it answers a lot of the important questions. But I don't think we should be using more government money. I think we need people wanting to do the right things. And those people are already there. They're already in the system. We need to empower them to do it. And I worked for 25 years with a management consultant, and I drove my staff crazy. And I'd take them away on retreats and feed them really well, and even serve them wine back in the day when that was allowed. But that consultant had 2 main points. He said you need to have a task orientation, or TO, but you also need to have a relationship orientation. And a good manager with only task orientation probably isn't any good for your organization. But if they have the RO and the TO balanced, you get some of the best out of people and some of the best out of the system. So again, I don't think it needs more money at all, more public money, but I think we need to use some of the resources that seniors already have. And while we have some seniors who are very poor and very destitute, we need to care for those. And we, as a society, need to care for those seniors. But we also need to allow those seniors who can to care for themselves. And I think that's where a new model needs to go.
I would just add Paul mentioned the value of community boards in the nonprofit sector. I was privileged to work with some of the earliest ethnic homes for seniors in this province, the Japanese Canadian community, the Ukrainian, and others. The value of this is that there are donors in those communities who, I'm going to use the word, casually write checks for $500,000 when they're needed. You're not going to get that in the for-profit sector. If $500,000 is put on the table, it's for a return on the investment. They want a profit to come back. The donors in community boards are simply wanting to give back to a community that gave them what they now enjoy.
If I could just comment further on that, somewhere in my paper, I believe I comment on it, but when we needed to fundraise to build our facility, we started a campaign, and I think I told our director of our foundation I needed $16 million from her at the time, and she said I was crazy and wondered what planet I was from. And we did, and we had professional fundraising consultants come in, and they said, all you can raise based on your history and based on your community is $2 million. And I went back to her and said, in that case, we're out of business. We went out and we did a campaign, and the first campaign raised $6 million from a lot of sources, the banks and all the usual suspects, but a lot of individual donors. In the second campaign, right after that, we went out on a $10 million campaign, and very early on, a family member of a former resident came to the table with a donation of $5 million. They came to the table because their mother, or the mother of the wife, had been a resident in a 4-bed ward in our home 12 years before, had been a very difficult resident. The family had no money at the time, and they just happened to sell the racetrack that they owned and came into a lot of money and wanted to give back. So there are people out there, and if they believe in what you do, they will provide those dollars. And it's another way of not using government money. The donor dollars are very, very important.
Thank you. My name is Frances Morton Chang, and I'm a CIHR Impact Fellow. And this conversation couldn't be more timely as we look towards the redevelopment strategies for long-term care. And I would just ask Lawrence and Paul to reflect on, as we build buildings that are going to last for the next 30 to 40, 50 years, and we know that almost 80% of people in long-term care tend to have a cognitive impairment, are we thinking forward for those folks, in addition to thinking about maybe even senior campuses as ways to try and have a continuum of care where people can live, and where that might even fit with the dementia strategy? Thank you.
I'm not so sure about the dementia strategy, but the continuum of care and the seniors campus has the potential for some absolutely amazing results. And the first facility I started in 1976 had a continuum of care, an elderly person center, seniors not-for-profit apartments, seniors market apartments, and residential home for the aged. The facility I last worked in for 22 years in Dundas, we started as just a home for the aged. We then added a very small elderly person center, expanded that to 4 specialty elderly person center, including one for people with dementia. And when there was no money, no government money available in the 1990s, we decided we still needed to care for the same portion of the population that we had historically done in our community. So we finally settled, after searching around the province, on the life lease model and added seniors life lease housing. Last week I was at the groundbreaking for a hospice that will be built on that site as well. So I couldn't believe more in the continuum of care and the importance of it. We also added at one point respite care, but not respite care just as a bed or two, but as a whole program. And that program component of respite care made it very successful. But again, there was no government money to do it, so we went to the local Rotary Club, who funded the program for 3 years. And I remember Joyce Cagill, who was the head of the PCS at the time, said, "There's no sense in doing respite care if people have to pay. There will be some people who can't afford to pay anything but who need respite care." So part of the Rotary money we set aside for those people, and they could pay nothing if they didn't have the ability to pay. Nobody ever used that money to the full extent, but we had it available, and a lot of those elements made that program a success.
In this redevelopment, I hope that the planning will include small clusters of pods with private rooms, small areas for dining, but the design be featured in such a way that it will meet the needs not just of a specific target group right now, let's say cognitive impairment, but will last in 30 years and can be adapted. What I have in my experience is, I remember when hospitals were building special sections with iron lungs. There was a heavy investment, and then Jonas Salk came along with a vaccine, and poliomyelitis disappeared, and the population that was using the iron lungs passed away, and that was useless space. I also know that during the first years of my directorship, the Ministry of Health was trying to get me to take over thousands of beds in no longer used tuberculosis sanatoria. And this province was dotted with huge buildings, private homes for the doctors on staff, and suddenly TB no longer was a primary health concern. It's still there, but not so much in the developed countries like Canada. So our planning really has to be forward-looking and be prepared to be flexible, because the needs of today may not be the needs of tomorrow.
There were two more, and I see you. You've been valiantly shaking your hand, so I won't forget you, and we'll just take those two more questions. Thank you.
Debbie Humphreys, Advantage Ontario. I listened with interest last week or so, a show on CBC, Why Are the Millennials Blamed for Everything? And I listened with interest because it feels like seniors are blamed for everything, and I particularly object to the senior tsunami and language like that has become the narrative, even within our own sector, even within our own ministry, that this is a problem, the demographics, we've got to solve it, and it just, the tone and tenor is concerning. And you made a comment earlier, Gail, about respect, and how do we get that back in the ministry staff, in our own sector, with the media? One sentinel event, as we found with the task force, colors the whole sector, and we're continually fighting to showcase the good against the bad.
I don't know how we get it back, but I can tell you from a very brief experience, it was supposed to be 2 weeks and it ended up being 18 months in a post-retirement career I did in Peterborough. And I went there, and St. Joseph's at Fleming had been identified in the media worldwide as the poster child for abuse of the elderly. A family member took some hidden videos, found 4 staff doing things that they shouldn't be doing, and they should never have done them. But the local TV station took those 4 videos and created them as if they were one event. 5 years later, those videos still play on W5, on the local Peterborough TV station. The local Peterborough newscaster made her whole career just on those 4 videos. And in my mind, the resident family member who captured the videos did a good thing. He found staff doing something they shouldn't be doing. Had those staff been witnessed doing those things, they would have got a slap in the wrist in 3 cases, and 1 of them would have been terminated. As a result of it being put together, all 4 of them were terminated before I arrived there. And I can remember arriving on scene and saying, those 4 staff people will never come back in my lifetime here, only to 9 months later eat those words when an arbitrator awarded 3 of them their jobs back and said, they did something very bad, but they don't deserve the death penalty, or they don't deserve to be terminated. You need to take them back. So I think the media is a major part and can take something that's very small, and that home still today suffers every time the Peterborough Examiner does a story, or the Peterborough TV station does a story on them. All the good news in the world, and it is a wonderful facility with wonderful staff, but all the good news in the world gets overshadowed by one video.
Hi, I'm Don Maston, and I'm a caregiver for my wife. She's passed away now, but since 2002, I've been following long-term care. And I just want to say to Paul that what I see, you're exactly right with these administrators. And I talked to the policy group in the government about it, and they told me that they're mostly trained on finances and that they were going to check into it. And now you brought it up, I'm going to follow that up and see if they have done anything. And your second thing was about inspectors. That 150 inspectors they hired are totally useless. And in industry in the 1990s, they did away with inspections. And you do your job right the first thing. And the trouble is, the care process, bringing the care from the nurse's desk to the bed, is terrible, and they've got to change that. So the PSWs have the tools to do their job right every time, 365 days a year. And that's where the problem is. You can't inspect quality into a process. If you talk to people, everybody knows that. And I don't know why they hired all them, but they got to change the process to deliver the care from the nursing station to the bed. Anyway, thanks a lot.
So I'm going to use this also, thank you for your comments, as an opportunity for you to respond, and then if you have any final words, words of wisdom you'd like to share, and then I see students clustering there, so we'll adjourn after that. So Paul, do you want to start, and then Lawrence? So if you could respond, and then if you have anything else you'd like to add.
Sure. I couldn't agree more with the gentleman, and a couple of things stand out for me in my orientation as an administrator, and I never stopped going to school. The other thing we did is every time I graduated from something, we had another baby, so I did stop going to school eventually. But I go back to the McMaster program that introduced me as an administrator in long-term care, and Debbie Vagoda, who was instrumental in that program. And she brought together a lot of people, and a lot of the program we had, I don't even know if we studied anything about finance in that program, but we sure studied a lot about the elderly. We learned a lot about boards. We learned a lot about auxiliaries. One of the best programs we learned was the value of auxiliaries and guilds and volunteers. And the ONUS leadership program, or the Advantage Ontario leadership program that operates today around that, does a lot of those same things, and is a great resource to new administrators in the field and those who want to be administrators. So there is some good work being done, but it's all about having the right people in the right place and caring individuals.
I just want to add that in terms of image, and Ms. Humphreys from Advantage raised it. You also have to look at the popular media, books that the general public read, novels, the movies they see. Long-term care is projected as something crude, funny. The administrative staff are shown as clownish. And one of the most popular books for a long time was called The 100-Year-Old Man Who Climbed Out the Window and Disappeared. Do you know why he climbed out the window on the day of his 100th birthday? He couldn't stand Director Alice, and he couldn't stand the home. And at the end of the book, they go through what he was told the day he moved in, and his answer was, "Can we go to the bathroom when we want to?"
Wise words on which to end. It falls on me to thank Paul and Lawrence and to thank all of you for what has been a phenomenal discussion. We've covered the waterfront, and I think we've left out so many things or touched on so many things. Profit, not-for-profit, funding, respect, status. Does any of this belong in the Ministry of Health in the first place? I didn't make any notes, but I'm sure you have a long list of things that bear further discussion as well. So thanks, Pat and Rhonda, for getting this going, and thank you very much, Paul and Lawrence. This has been a wonderful morning. Have a great day, everyone.